Hello and welcome to the Canine Rehab Movement Podcast, where we discuss all things canine rehab, fitness, and sports medicine for our four-legged companions. We cover a variety of topics with amazing guests in an educational and entertaining format. Some would even call it edutainment. Now, we are all about canine rehab and fitness training, or craft. So join us and hone your craft with the Canine Rehab Movement Podcast. Now, today's episode is sponsored by Zomedica. And at Zomedica, they're committed to meeting the needs of clinical veterinarians and rehab therapists in ways that promote both patient and practice health. It is their mission to advance the effectiveness of veterinary practitioners and rehab therapists by offering innovative, unrivaled products and services. So thank you again, Zomedica, for sponsoring today's episode. Now, in this episode, we have Dr. Michele Broadhurst, Doctor of Chiropractic, internationally certified sports chiropractic physician, fellowship from the International Academy of Medical Acupuncture, certified animal chiropractor with the International Veterinary Chiropractic Association, a certified canine rehab practitioner, as well as a certified small animal myofascial practitioner. So Dr. Broadhurst grew up in Cape Town, South Africa. She received her DC from the Durban University of Technology in January of 2004. She is certified in rehabilitation, chiropractic, and myofascial techniques. She is a human chiropractic sports physician and chiropractic acupuncturist, as well as holds licenses in 3 states. Dr. Broadhurst is on the faculty for Northeast Seminars in NC State CSMP program. She has a small animal practice in Coppell, Texas, and a large animal practice in Colorado and Texas. So, Dr. Broadhurst, thank you so much for coming on today. And how are you?
I'm doing great. How about you, Anthony?
I'm doing well. I'm excited about this topic today. It's been a front runner for about a year now, and I think it's something that has been overlooked in the past. And I think that it's really great you were able to join us today to really dive deep into it.
Thank you. It's something I'm very passionate about.
Yeah. So let's get into it. What would you say the principles and kind of the objectives are in myofascial therapy?
I think in order to understand that, we need to actually extrapolate a little bit from the human world. So
Sure.
what we found in over the last 15 to 20 years, where myofascial, I would say, it's got even bigger, but it's been big for a long time in the human world. Now it's getting even bigger, because what we're finding from a research perspective is that 80% of musculoskeletal pain comes from a myofascial source.
Yeah.
So that is huge.
Yeah.
Huge. In veterinary, we always have discounted the myofascia almost up until very recently, where it started to lap over into the animal world. So my belief system is that, yes, we have a lot of pain from joints and inflammatory processes and all of that, but I certainly believe that we discount myofascial pain significantly in veterinary, to the point of really just almost ignoring it. And because of that, we actually end up in a much worse position with our patients than what we have to be.
Yeah, totally. And I think it goes to that fundamental saying, it's all connected, right?
And thing.
If there's joint pain, there's got to be something going on with the muscles, the myofascial. It's all just, everything needs to be worked on for sure.
Yeah.
So what are some of the various techniques that are out there? Any kind of specific applications that you would use on maybe different kind of canine conditions as well?
There's so many. So when we look at the myofascial system as a whole, we're including the muscle. We're also including the fascia, but in conglomeration with that, the fascia is actually what, during the developmental periods, it creates the ligaments, it creates the bursae, it creates the tendons, It's
Mhm.
all of that and more, all interlinked into a massive 3D matrix.
Yeah.
So I think when you're looking at treatment protocols, one has to keep all of those things in mind because they really are this magnificent complex of interrelated and overlapping features. So when we're looking at myofascial pain, we use myofascial pain, myofascial trigger points very into we mix between them, which may or may not be
Yeah.
right, because myofascial pain is one entire system pain, whereas myofascial trigger points, we're dealing with referred pain, we're dealing with localized pain, we're dealing with certain elements that make a myofascial trigger point, which is different from the whole myofascial pain syndrome. So I
Yeah.
think that it's important to be able to differentiate between the two. And in most cases, people don't know how to do that. And so when we're looking at techniques specifically, there's a bunch that we can use. These are always your best tool.
Of course.
And
Hands, right?
absolutely. And it's the cheapest, except for the
Yes.
communication that goes into them. But I think using your hands and palpation is important. So the palpatory
Absolutely.
techniques you learn as a veterinarian or a vet tech are very different to what you learn as a PT, a chiropractor, an osteopath, a manual
Mhm.
therapist, so to speak. For PTs, chiros, osteopaths, there's a huge emphasis on being able to palpate tissue. Whereas in the veterinary world, there's a huge emphasis on being able to palpate organs and so on and so forth. So
Mhm.
the real emphasis is being on palpation and being able to diagnose effectively, because if you don't know what you're treating, you really have no business treating it.
I agree thoroughly. But
So,
yeah, it goes back to seeing with your hands, right?
and I think that's where a lot of people get intimidated and a lot of people get
Mhm.
overwhelmed, is the ability to palpate and be able to diagnose and identify what they're actually feeling. And one of the biggest things we talk about in the course is I don't overstress that everybody needs to know every insertion and innovation, but you certainly need to know what that muscle is meant to do and what's in that
Mhm.
surrounding area. Because if we don't know what its function is and we don't know where it goes to and comes from, then
Mhm.
we often aren't actually able to elicit the responses that we want or need.
Yeah.
So there's a multitude of modalities that we can use. Laser, extracorporeal shockwave is one of my
Mhm.
favorites.
Yeah.
You know, I use a lot of modified AR.
Very cool.
I love Graston type techniques, so
Yeah.
instrument adjusted soft tissue techniques. Acupressure is amazing. All you need is a
Yeah.
thumb.
Right.
You
Thumbs
know,
up, baby.
rolling. Exactly. You're rolling it, all of these different things. But I think the most important thing is knowing when to use what in which case with which patient.
Mm.
So
Yeah,
if
for
you have
sure.
a super young dog with a TPLO that is like trying to run around after 3 weeks and
Mm.
has no other issues, it's a very different patient to your dog with severe hip dysplasia,
Mm.
spondylosis, and now a deformity in the forelimb because of overcompensation. Very different workup, very different dynamic. So
Yeah.
there's so many. Dry needling is obviously something that I really enjoy teaching, and it's been incredibly helpful for the patients. It's not in everybody's scope of practice, unfortunately, but for the
Yes.
veterinarians that can do it, it's
Mhm.
amazing. And we see very good results from the people who've done the course, really rave about it, which has been great. So there's a multitude of different things, and there isn't one thing that is like the overall, this is the best thing ever. There's a
Yeah.
whole bunch that you can use as and when you need it.
I absolutely agree. And just to dial back for those maybe in the vet world that don't know what it is, ART. I love ART. Could you go into what ART is in a small synopsis, a nutshell, if you
So in a
could?
nutshell, it's active release technique. So what you're
Yeah.
actually doing is you are using um, the body's natural mechanisms of stretch and release to
Mm.
basically fire up a muscle or the fascia in order to release an area or activate it. So depending on the
Mhm.
technique that you're using, it's a little bit, I don't want to say it's like kinesio tape, but in a way
Mhm.
you're using it in the same capacity. So you can either get a muscle or a ligament or whatever it is that you're working on to activate, or you can actually de-stress it, depending on the
Yeah.
technique that you're using.
Yeah, I could see the common theme there to either facilitate or inhibit in that sense.
Exactly.
Yeah, with K tape. Very cool. Very cool. So let's go over the role and maybe the impact of myofascial therapy that's now coming into canine rehab. There's been a lot of theme to it in the past year that I've seen. And just for the listeners out there, why should they include it?
Without muscles and fascia, we would just be a crumbling heap of bones on the floor, which is not super awesome. So when I went to school, when the ark was being built, I remember my first 2-3 years of anatomy dissection, and they were like, "Oh, just get that pesky white stuff out the way. It's so annoying. You just got to rip through it. Just put your hand through it and pull out an organ." But what we didn't realize is that the entire foundation, they were dead people. To be clear.
More fun.
The entire foundation of our bodies is held together by fascia. So it's so naive to believe that it's not only one of the most important, if not the most important network within our body, but it provides many different things than what we thought before, from lymphatic drainage to neurological processings and synapsing. The entire nervous system runs through the fascia. And so by eliminating it and not really including it, I think we really, we'll do a joint injection. Okay, so you have a dodgy hip and we've got osteoarthritis, but what about all the compensatory mechanisms that go into that and the patterns that we see? And so often where the pain initiates is not where we're actually seeing the compensation and the issues a little bit further on down the line. And that's very much the myofascial and the functional element of it. Being able to really identify how things work together and the compensations, what one means to another one, and kind of mapping out the relationship is really important, because otherwise you're going to miss things further down the line. And all of a sudden that hip, now we've got an elbow, now we've got a shoulder on the compensatory limb, and we've got spondylosis and osteoarthritis in the back. And so this dog's quality of life is limited because we haven't really looked at the surrounding structures and the things that actually keep them going on a functional level.
Yeah, totally. And I love that you brought that up, because I think every assessment with the patient in front of you should be at a functional level, not just at that medical diagnosis that's sent to you. Absolutely. So what would you say is, or if you could, share some memorable case studies demonstrating some of the effectiveness of that myofascial therapy?
I think so often we see good surgeries go bad. It's not really the surgery that's gone bad. It's not the rehab, but the post-surgical endeavors, if we can call it that. So one of the biggest things that I talk about in the course is I talk about the compensatory muscles that are included in things like cruciate surgeries. And important is to identify and release those compensatory muscles, because they can make all the difference in how that dog is actually going to be able to walk and ambulate and not blow out his other cruciate. So by releasing things like the gastrocnemius and the sartorius, you can literally increase not only the amount of extension in the leg, but you can actually increase the amount of time that we have as far as placement and and actually weight bearing goes by up to 50% by just treating the myofascia.
That's huge. Not a small number by any means. No.
And it's quick. It's quick.
Yeah, exactly.
Like from where the dog walked in to when the dog walks out, it's one day. And it's, even though you may need to do multiple treatments, it really holds pretty well if you are treating the source, not the compensation only.
Yeah, and I think even if you have a stubborn dog and you get that, and then it might not hold as much, you can go back to that K-taping, right? So to facilitate what you're trying to do.
Absolutely.
So there's definitely many tools in the box. I know that's not myofascial, but there's tools out there to help prolong that effect as well, for sure.
And people also forget that they always think myofascial really sits in the realm of orthopedic, and that's not true either. I have a case right now, which is a corgi that has had failed cruciate surgeries and a failed hip surgery. This poor dog, he is just tragic. And he hadn't put any weight on the affected limb for, I want to say, 8 months. He hadn't even been able to touch. And his entire portion of his rectus femoris, as well as his sartorius, his iliopsoas, was super shortened. He had no hamstrings, glutes. His TFL had atrophied. He was overloaded through his QLs. And within 3 sessions of doing purely myofascial work, this dog is toe touching.
I think that's an amazing kind of example right there too. And also for practitioners to think about, sometimes all you need is manual therapy for a session, right? You
Mhm.
don't need to rush into underwater treadmill, laser therapy. Yeah, those help. Use what works, right? Use, like you said, those hands should be your number one priority
Mhm. Yeah.
on feeling that patient, treating that patient. And I think that's a really good example of having that back-to-back hands-on therapy approach that you did there. And it's a really good key point for those listeners.
We are being programmed that we need all of this expensive equipment. And don't
Yeah.
get me wrong, in my clinic, I have a shockwave, I have a laser, I have underwater treadmill, I have all this.
Yeah.
And the reason I have them is I love to have a box that I can pick and choose from.
Mm,
But I don't really believe in a standardized approach. And there's a
yeah.
lot of clinics that do that. And I understand their perspective too. But just the way I practice is I'm going to treat what I see on the day. And that my plan may go out the window completely. But having those tools around me are super helpful. But it's
Mhm.
not always my go to for everything because that may not be what the patient needs.
Yeah. No, for sure. And I can tell you in the years that I've been treating too, I've found myself teetering away, even from the underwater treadmill. Some cases absolutely need it, but not every case.
Mhm.
And yeah, you really do see more of a result and just confirmation and taking away that imposter syndrome with your hands. Like
Mhm.
your hands do so much.
Mhm.
So I think this is really good key points you're bringing up here for sure. Let's discuss maybe some of the challenging cases and what techniques you possibly apply to overcome them.
I think neuro is always everybody's challenge, right?
Mm,
Those
yeah.
IVDD dogs, the hemi-lamb cases that are not responding,
Mm,
they didn't respond to surgery, they're not responding to treatment. I think those are some very challenging cases, especially
mm,
because you throw in the level of paraspinal atrophy that goes with that, and everything
yeah.
below the lesion is a very challenging thing. I have a tendency to get those dogs in a wheelchair very quickly. And
Okay. I
I
like that.
and I do that not because I don't want them to not walk again, but I find that
Yeah.
I'm just thinking about one of my patients who's actually coming in this afternoon, and it's a French bulldog. What a surprise!
Of
And multiple discs,
course.
and
Yeah.
was in surgery within 12 hours and is just not responding. So what we've
Hmm.
actually done is put her in a chair. We're dealing with some heavy compensations in the forelimb, and that is one of my biggest reasons for putting her in the chair is because she's got no back legs at this point. And there's
Yeah.
only so much that I can do from a treatment perspective to stop her from getting a supraspinatus and a bicep tendinopathy because she just
Yeah.
wants to scoot around all the time. And bless her parents, they're very lenient with her. If we have two bad legs, that's one thing. But if we have four, we're in big trouble.
Absolutely.
So I think that's one of the those are cases that are fairly frustrating because neurology is really slow. So as much
Yeah.
as we do neurostim and upregulation of the nervous system, it's still super slow, but we've got to not forget about those compensatory limbs too. So that is thoracic limbs that
Absolutely.
are just doing everything. And there's a really good chance at some point those will fail, especially in
Hmm.
the dogs who we know don't have fantastic spines either. And now we are
Yeah.
heavily loading onto that forelimb. We're got our neck in a different position. So I really like putting them in wheelchairs to do therapy with them and
Yeah.
also to get them out and moving in a better position so they're not pulling all the time on that forelimb. There's little things like that I think make a big difference to your success rates with these
Hmm.
patients. But yeah, what is your experience?
Two key points that I heard from you, and what I really would love to dive into is obviously the first one is always go for the collateral secondary issues, and that's why we always assess functionally. But yeah, those shoulders, those biceps, those really need to be treated right away. But the biggest one is carts. And I think the biggest misconception is that a lot of people think carts are like in the human world wheelchairs, but we're actually using the carts to keep them mobile not to suppress them, right? Or
Correct.
take away mobility. So that's the biggest stigma I've also been trying to educate on,
Mhm.
because I agree with those neuro patients. If you can get them in a cart right away, even just that mind body connection with that cart is huge. And so I think there's a stigma out there that some people still think if you put them in a cart, this is bad news. Not at all. I've had some neuro patients start in a cart and then get out of a cart
Mhm.
because the cart was the facilitator, not the
Mhm.
inhibitor.
Mhm.
So I think that's a really huge key point. Absolutely.
Yeah, I
Um,
do that with my DM patients too, is I
yeah,
put them in a cart really early, long before they lose function.
yeah,
Because if you look at the human world, and I was a sports physician before I did this, is you can actually get with the Olympic athletes and you watch the research
mhm,
and they will literally run a race in their minds and their body functioning and their nervous system will respond as if they're running, but they're
yeah,
literally like a little bit of a hypnotic state going through that process, but everything will relate to what the brain thinks it's doing. So I
yeah.
kind of bring that across into the animal world. And I'm like, if the
That's
dog
great.
thinks it can walk, the chances of it walking for longer, I'm not saying we're going to cure DM
Of
or don't
course.
understand, but if we can keep them walking for longer, that's maybe a month, 2 months, 3 months of more quality of life than what they would have had without it. If we can trick the brain into thinking that it's doing
Yeah.
something, there may be a really good chance that it does.
Yeah, no, I love that concept. And I hope the listeners run with that as well, because I think it's something super important, especially for DM, right? Our goal is
Mhm.
to prolong the progression,
Yeah.
right? We're not reversing anything. It's not there yet in what we can do with that. So, yeah, that's what we're looking for, quality of life and prolonging that progression. Absolutely.
Yeah. And
That's
again,
awesome
same,
viewpoint.
same issue with DM is we've got caudal atrophy and weakness, and
Mhm.
poor cranial aspect is just taking everything on. And very often that's actually what causes their demise, is that they just can't pull themselves up anymore. From a myofascial perspective, working on that and being really focused on what you can change is so much more important than trying to focus on what you can't.
Yeah. No, I absolutely agree. Do what you can and hone in on what you can. Don't try to go too far too fast. Absolutely. I agree with that for sure. So let's talk about maybe possible advancements and ongoing research that you've either seen or are seeing now in the myofascial world.
What's very cool is we're learning more and more about fascia all the time, and there's actually a
Mm,
fascial institute which I belong to, and there is fantastic research. If you guys are interested in fascia, I highly encourage you to look at it. In the
yeah.
in the equine world, there's a book out on the chains, the myofascial chains,
Hmm.
which very much mimics the concept of Tom Myers,
Okay.
which is interesting. And I think, no, and I mean that from a really good perspective. I think it's interesting because it brings in different people's opinions, brings in different ideas. And I think that the myofascial is so much more complicated than we even have a concept of.
Mm,
We think that it starts out from an embryological level, it surrounds every nerve fiber, it creates blood vessels, like the actual lining of the blood vessels, it surrounds every myofibril, it surrounds every muscle, every organ,
yeah.
lets everything slide, it supports, it nurtures, lymphatics,
Yeah.
neurology. Like none of us knew any of this stuff years ago, and now it's becoming more. And it's interesting because in the acupuncture world, we always had this meridian called the triple heater or
Mhm.
triple warmer or Sanjiao, whatever it is you want to call it. It's all the same thing. And none of us really understood what it was, because it wasn't like, oh, your spleen meridian, oh, your kidney meridian, oh, your bladder, whatever. And now what they're actually finding is that the San Juan, or the triple heater for English cases,
Mhm.
is the fascia. And so everything
There
that
you
they're
go.
talking about for the longest time about the relationship, and really what the triple heater does is it connects everything together. And that's, I think, what fascia really is. And that's what we're
Yeah.
realizing more and more. We just don't completely understand how. So we're learning all of these tidbits about what it can do and how it's effective. But I don't think we've really put it completely together. I know I certainly haven't. The more I read, the
Mhm.
more I'm like, okay, cool. That's just another piece of something.
Mhm.
So the pieces are coming together. So I think that the fascial chains are interesting. I don't think it really changes from my perspective. And this is totally personal. I think they've done great work with what they've done. I don't think it really changes how we treat. Because at the end of the day, it comes down to this again, and feeling and finding fascial adhesions, where things aren't
Mhm.
sliding, looking for puckering of the skin. How are things not working well together? I don't
Mhm.
think it's as simple as going, okay, we're dealing with just with this chain or this, and
Yeah.
that I know has been a bit of controversy with Tom Myers and what he brought out. And I don't think it needs to be controversial. I think it just adds another element to myofascia, and it
Yeah.
makes us look at it from a different perspective, which is fantastic. But I don't think that there is, and they're not claiming it, but I don't think there's a one size fits all. There's not just one point you treat to get rid of that whole system.
Yeah.
It's a little bit like believing we're alone in the universe.
Right. Yeah, no,
Like
absolutely.
if
That's
it
a good
was,
way to put it.
everybody would just be doing one thing, right? If
Yeah,
it was one
I
baby book, everybody would
yeah.
raise everybody the same. It's I don't think it's that simple. I think it's like the stars. I think there's so many ways, there's so many layers, there's so many different ways of bringing it together. And the more we learn
Yeah.
about fascia and how vascularized it is and how it regenerates and how it
Mm.
changes and how it can, we look at scar tissue, and scar tissue always used to be scar tissue. Now it's not. Now
Right.
it's connective
Yeah.
tissue, and it's fascia, and it's fascial adhesions, and it's layering,
Yeah.
and all these different things. And now we know, like, by doing something like shockwave or needles and creating angiogenesis or
Yeah.
stem cell activation of endogenous stem cells, you can change so much in a quick period of time.
Which
Um,
is huge. Yeah.
there's so much research going on, and there's so much cool stuff going on, but we're picking stars. We just haven't
Yeah.
got the whole thing. And I think for a lot of people, they want a quick answer and they want a quick fix. You
Yeah. Of
live in
course.
Starbucks drive-through world, right?
Yes, we
Oh,
do.
cool. But like with this, I can just stick a needle in the hamstring. No, it's not
Yeah.
that easy. But again, we got all these compensations, all these different things.
Yeah.
Bob the bulldog is not the same as Becca the whippet.
Yeah.
So,
No, absolutely.
um,
I agree because I think a lot of our techniques are different, right? So
mhm,
as practitioners, and then yeah, a lot of how patients react are going to be different too. So it's not just the North Star we keep taking from, right? There's so many other stars out there that we might have to take from. So
yeah.
I do think that's a perfect example. And I do like how you brought up, do think a lot of people still don't know that connection.
Mhm.
So great point. Thank you so much for that. So let's go into the education of it and get into the course. You're the instructor of that course. Can you give the listeners just a little bit of information on what goes into the course, what goes through the course, everything like that?
Sure. Matt Branke and I designed the course
Mm-hmm.
together, which was great. And Matt's got other stuff going on right now. So he's no longer doing the course, so we've got Dr. Caitlin Leonard, who
Okay.
is a DBM and a chiropractor and an acupuncturist and all these things,
Very cool.
who's also helping us teach. It's awesome.
Yeah.
I'm not an academic by any stretch of the imagination. And so I don't teach like an academic.
Okay.
And the reason why I bring that up is because I'm not going to sit there and talk to you about stuff that's not going to help you in practice. The worst thing for me, I am registered in 4 states and I have to do CEUs for all of
Yeah.
them and for all my specialities.
Oh boy.
So I have to do a lot of
Yeah.
and my biggest frustration when I do it is I come away from 3 days of my life and I have maybe something that I could have learned in 10 minutes.
Yeah. Unfortunately.
And it's torture. It's really torture. And I think right now in the veterinary community, we're dealing with a lot more contentious issues than we ever have before. People have less money. We have less time, especially in a corporate environment. The demands are much higher than they've ever been. Clients' expectations are higher than they've ever been. And their willingness to pay is at an all-time low. So one of the biggest things that we try to teach in the course is that people come away with a tool that they will be able to take back into clinic the day of and actually start implementing it. And what our focus is on is really understanding the basics of myofascial therapy. By no means are you going to be an expert. In fact, at our last course, they were laughing at me because I stood up and I said, guys, don't worry, you're all going to suck at this. But by the end of the weekend, you're going to suck a lot less. And it's just because it's not something you know.
Yeah.
And that's totally, so a skill is not formed in a weekend.
Mm-hmm.
It's not formed in a week. It's formed in a month. It's formed over doing something repetitively for hundreds and hundreds of hours.
Yeah.
But what we're going to teach you is the basics of palpation and how to actually start to trust your hands instead of your brain, because that is one of the biggest issues. It's everybody everything, and actually be able to identify things with your hands instead of, and get to grips with what myofascial pain is, what it means for your patient, and the options you have in treating it.
Yeah.
That's really where the theory comes from.
Okay.
When we hit the lab, we probably have 15 to 20 minutes of lecture throughout the entire, and everything is practical. So
that's huge.
By that point, everybody should know the basics. We don't go back there. We've done the lectures. You guys have the books, and really, that's your responsibility. So I like to treat people like they're adults.
Yeah.
You stand up for it, read the book, watch the lectures. Now we go to the lab.
I love that.
So we have small groups. We go through thoracic limb, pelvic limb, palpation, different techniques. You get to try out the different techniques. We work up cases. We evaluate the different cases together, and it's a very kind of open forum.
Yeah.
And really, at the end of the day, is I'm just there to make you guys think.
Yeah.
And to know a little more than what you came in with, so that you can find 5 minutes as a veterinarian. You can start playing with needles, and it takes seconds to dry needle a trigger point or a fascial adhesion, and it can make the world of difference. For the techs, this is how you use a shockwave. This is how you use your hands. This is what we're going to do. So we try to approach it from all different angles, so that whatever your discipline is, you can walk away with something that is going to be beneficial to you in practice. And that's really the goal. Is we're trying to give you as many pearls as you can.
Yeah.
What you choose to do with those is completely up to you, but we would like to at least have you walk away with a lot more knowledge than what you had before, and a lot more confidence. It's really a big confidence thing, because it is very outside of the realm of even the rehab courses or anything. It's very different when you start working in the myofascial world compared to talking about exercises and all of that kind of stuff.
Yeah. No, for sure. And I even think when you compare it to like the manual therapy courses, this is still just a little bit, obviously it's parallel to it because that's part of manual therapy, but this, for the listeners out there and people who are interested in it, this is diving into it, right? And this is really going into using your hands first, and then knowing the modalities that can either facilitate things like that, whether you want to use it before, after, things like that. It's all up to the practitioner. And I think one of the best things that you said was it's about confidence. That's huge, right? Everybody reads the books, gets the theory, starts doing it hands-on, but they don't always get an instructor or have a course where they help with the confidence, right?
Yeah.
So that's super huge and a great takeaway from all of that. Absolutely.
Yeah. I think the other thing that we need to look at as lecturers, as teachers, as instructors is the body tells a story. And we get so fixated with one thing. And you have a stifle case come in, and it might be an MPL, it might be a CCL tear, it might be whatever. And we're so focused on that stifle that we're not thinking about why that stifle blew in the first place, or why that tore, and it really does. If you just take a moment to step back and see the story, because there's a story to everything. I had a vet in here on Monday, and with her dog, and I was like, oh, but do you see this? Then this is causing this, and then that causes that.
Yeah.
And she's just, okay, you have to tell me that again. And I was like, okay, this is the story.
Yeah.
And it's a story. Myofascia is a story.
Yeah.
It's like the universe, right?
Absolutely.
It's a story.
Yeah.
It's not just this. It's not a TPLO. It's not a total hip. Those are very structured. It's A, B, C, D, E. This is what you do to have a successful surgery. And thank God for that, because it allows orthopedics to be very standardized. Myofascia is like the tree hugging sister from the 60s. Like, it's super fluid. It moves, it flows, it changes, it his mind and does something else. And then, but you got to understand the story. It's not clear. It's not okay, if you got this, then look for that. And that's what people are looking for. And that's not how it is. So you have to actually get into the story to really understand it. So, and be able to flow and be able to adapt and change. And that's because the myofascia is doing that all the time.
Yeah.
And that's, you were asking about research, is that's one of the biggest researches that we are finding, is that the myofascia is completely not constant.
Yeah.
It's constantly changing. And so we have to change with it. You can't have a 12-week protocol for myofascia, because the next time your patient comes in, there'll be something totally different.
Yeah. No, and again, that's huge. And it goes back to that functional diagnosis versus medical diagnosis. You have your GP vets that are just very medical, right? They have a medical diagnosis. They're sending you a stifle case and they're just thinking about the stifle, and that's it. But yeah, with that functional assessment and diagnosis, you're getting the story of the entire body, not just of the stifle. Yeah. So a really good key point there as well. But Dr. Michele, what would you say your predictions or maybe aspirations are for the future of myofascial therapy?
I really wish it would be a much bigger interest in veterinary school. I think it's glanced over very quickly, and I understand they only have 4 years to do every animal, everything that they do. But I think we really sideswipe myofascia out the way. And I think it's one of the most crucial elements to the body functioning as a whole, because if you understand how it all comes together, it's really important. And also just being able to look outside the box a little bit. The veterinary paradigm has been very strict in the way that it's been taught. And if we've learned anything from things like osteotomy, so the DOs, there is a lot of leeway to still be super clinical and very relevant and very, peer-reviewed, study-based, but also look at things that which are, but haven't been included. So I think if people could really view the body as a whole and address it from every element, and even just understand the basics of that and then go into it as a postgraduate or whatever it may be, I think it's really important. But I don't think we're there yet. I don't think that on a veterinary level we are even close to seeing the body as a whole structure that is working. We see it as working independently from each other, and it's not. Yeah. It's a very interconnected, completely symbiotic environment which works off each other. And I think if we could understand things like myofascia better, we could actually diagnose other issues that are coming up a lot sooner and really improve the quality of our patients' lives.
Absolutely. Yeah, I think if we can keep it in the spotlight and obviously have advancement in research, hopefully those schools will start to integrate something, whether it's at least an elective, but hopefully a main course as well. Yeah, absolutely. Dr. Michele, I do appreciate you joining us today. This was really insightful. We'll put everything you've mentioned in the show notes for some of the books, research, everything like that. And we hope to see you again.
Awesome. Thank you so much for having me. It's been great.
Thanks so much. You've been listening to the Canine Rehab Movement Podcast. Thank you for tuning in. And for more information about our programs, please visit ncsuvetse.com. That's ncsuvetse.com. And for those of you who've made it to the end of the podcast, use the discount code NCSU100 and save $100 off of any course, $4.99 or more. Until next time, guys, this is the Canine Rehab Movement Podcast.